Support for this podcast comes from iTube.net. iTube is optometry's leading source for high-quality optometric videos, educational series, spotlights, and more.
Hey everybody, welcome to another edition of Collaborative Corner, the podcast. Today, our guest and I are going to discuss a little bit about, refractive surgery. Honestly, it takes me back because, when I first started talking the word co-management or cooperative care, it was always just about like LASIK surgery or cataract surgery or PRK or RK. And I really feel like that term has evolved into any type of cooperative care that we have, either whether it be interoptometric or within ophthalmology or even just within primary care or other specialties. But I'm really excited to have with me today Dr. Justin Schweitzer, and Justin is coming to us from South Dakota, right, Justin?
South Dakota, Sioux Falls. You bet.
Yeah. The Vance Thompson. Is it the Vance Thompson All-Star Clinic of Eye Care Professionals, or what's
we like to go by Vance Thompson Vision.
VTV? Love it. But you guys are not just, so this is something that kind of surprised me. And if anybody just wants to hit 1.75 and speed this up, or just hit the forward button and go ahead 45 seconds. You guys are not just in South Dakota, right, though? You guys are outside South Dakota?
Yeah, we are. So when I started in 2012, it was one center, Sioux Falls, and we've expanded to, I'm going to get in trouble if I miss this, but 9 centers across kind of the upper Midwest, Montana to Iowa to Minnesota to North Dakota to South Dakota to Nebraska and Colorado.
That is impressive. So, I've obviously been practicing a lot longer than you, 30 years ago when I started doing my residency, and we were doing some clinical trials in and around our practice, but it was always kind of, what's Dick Lindstrom doing in Minnesota? Or, what is Vance Thompson doing in South Dakota? And it always kind of blew me away. It's like, South Dakota. And then I remember going up to the practice, and I was just blown away. It wasn't the glass cathedral that you guys work in now. And for those of you who remember the Restasis commercial with Allison Tyndall, right?
Dr. Tindler, yeah.
Allison, yeah, Dr. Tindler. That was your practice, right? Where she's walking around that just ridiculously amazing looking practice. Yeah, it's insane. So you guys do a lot of clinical trials. Anything you want to share with us that you guys are doing right now?
Yeah, sure. I mean, clinical trial stuff, as you mentioned, is exciting. It's new. It kind of keeps you on the cutting edge of things. We're doing some IOL studies, some new extended depth of focus lenses that are always, fun to work with. We're working on a new glaucoma drug pellet that's being looked at from a drug delivery standpoint that I think will be something exciting in the future. I think that's a big area that I'm passionate about as well, and some of the things we're going to talk about tonight. But I think that, research moves things forward. We got to have it. It can be tedious at times, Mark, but important.
I mean, what's more gratifying too, though, is when you're in a trial and you see patients that are excited, and they're like, when can I get this? Or how could I be a part of this? Especially from a therapeutic or a pharmaceutical trial. From a device trial, like a lens or even a laser device, it's exciting just to see them get treatment before other people got it, to be able to benefit from that. So I think I mentioned the last podcast, we were waiting for Alcon to get their PDUFA, and they did. I may mention it. Time is a flat circle for me, but this is Tripteer. This is their Trip M8 receptor drop for dry eye. So that's going to be coming at you fast and furious, probably this month. We've got a couple other, PDUFA dates rolling up very quickly too. But let's talk a little bit about refractive surgery. So, Justin, if I said to you refractive surgery, what's the first thing that comes to your mind?
Typically LASIK. That's what we think about. But boy, it's expanded. There's so many different considerations around it besides just LASIK. We have PRK, we have refractive lens exchange. You think of, ICLs. There's just a variety of different things that I kind of think about.
Yeah. So So walk me through this real quickly. So if I'm a co-managing doctor, I'm somebody who's coming into the practice. I have a patient there, and they're like, "Ah, God, I hate my contacts. I hate my life." You've tried the 1 days, and also I believe Alcon has a brand new multifocal 1 day. Just thought I'd throw that out there. And they're like, "I just don't want to do this anymore." The OD says, "Well, hey, maybe you should think about LASIK surgery." So now you have a patient who comes in to see you, and they're like, "I just want to see if I'm a candidate for LASIK." So I'm going to give you a scenario. They're a 35-year-old. They're -6 diopters with 2.5 diopters a cylinder, and their thickness of their cornea is about 510. What's your conversation with that patient?
Yeah, that's obviously saying that the topography or tomographer looks normal. We'll put that out there. With that type of refraction, I think there's really a couple things to think about, and that corneal thickness being on the thin side. I bet we could squeeze by with LASIK. I bet we could still
Wow,
doing the
really?
calculation. It'll be close. I want to have at least 300 microns of stromal bed left afterwards. And doing the calculation in my head really quickly as you were saying it, it'll be really, really close, with a wave light type of laser. I probably lean towards talking to that patient about an implantable collamer lens or an ICL, and specifically Evo, because at 35, we're still going to probably give that patient, a good 8 years of wonderful vision before, and they have to be educated on this, that their near vision may start to decline a bit. And we're not touching the cornea with that ICL. And so we're almost bridging things until they get kind of that presbyopic state. And then when they hit that presbyopic state at that 43, 44, then I think, Mark, we're going to start talking about a couple different things. One being, would we consider a presbyopic pharmaceutical option for them to kind of help with that near? Or could we consider doing something on the window of the eye, doing some type of refractive procedure like a LASIK or PRK, where you offset the eyes slightly? That'd kind of be my discussion with them, because I like to prepare them at the age of 35, but I also like to prepare them what to expect 8 to 10 years when they're having some changes to that natural lens.
I kind of didn't tee it up the way I really wanted to. I wanted to make it so LASIK was not an option, but yeah, I smell what you're stepping in. So I guess my point I'm trying to make is that I feel sometimes when patients come in with a certain expectation, because refractive surgery, as you said, and I totally agree, it's LASIK. It's like, prove it's not LASIK otherwise. And then you throw them a curveball and you say something like, look, we're going to put a phakic IOL in. It's got a little port in it that makes it the Evo, so we don't have to do a PI, and it's phenomenal. It's less invasive than LASIK because you're just making a small incision. We're not taking anything away, but we're also going to charge you, more money than you probably expected. So how do you deal with the patient who comes in with the expectation of one thing, and the whole intent is to have a evaluation for you to tell them what's in their best interest?
Well, I think you hit it right there, their best interests. I'll give them their options, but I'll be very transparent with them, look them in the eyes and say, corneal refractive surgery, LASIK in this particular situation, or PRK, you shouldn't have that done. It's not the best option for you. If you're my brother, sister, mom, dad, I wouldn't do that. What I would do, and it's going to cost you a little bit more, would be an implantable collamer lens like Evo. It fits better for your particular situation. You may ultimately decide that financially it's not the right choice for you. I'd rather you walk out of here doing nothing than to do LASIK or PRK in your particular situation. And it does matter on the situation.
Do you guys charge for the refractive evaluation in your practice?
We do not charge for the refractive evaluation. It's really just an educational visit where, we give them all their information.
Right. So I love that. And I think for me, and I don't know if you'll agree or not, and if you don't, nobody can see the expression on your face. But when a patient comes in, I look at them and I say, I'm here to tell you why you should not have surgery. My job today is to find reasons for you not to have surgery. If I can't come up with a reason not to, then I'm going to tell you what procedure is going to be in your best interest.
Mark, I agree. I mean, I have no problem telling a patient, hey, if you're comfortable in contact lenses or you love your glasses, we're not going to do surgery on you. We're an option. We're available to you for these different procedures. But please, if you're comfortable and you like the vision you have with your glasses or contact lenses, continue to keep doing that.
100%. I mean, again, it's an option for patients. We are comfortable with what we do, but we want to make sure that if you're going to do this, you're going to get the absolute best quality of vision. And oftentimes, LASIK may be the option. PRK may be a better option. An EVO lens may be even the best option. Doing nothing may be an option. So talk to me. You guys do SMILE in your practice, and I don't think a lot of ODs know about SMILE. I don't know where it fits in there, but what's your decision tree if a patient coming in, do I do LASIK? Do I do PRK? Do I do SMILE? Because those three corneal refractive surgeries to me kind of almost feel a little bit kind of like interchangeable.
Yeah, so we don't now do SMILE. We did. We're talking about bringing it back in just because there's been some changes around it. It's still, it's a procedure that I'm very, very interested in. We talk about it all the time within our practice. We were part of the clinical trials for a long time, so I'm very familiar with it. SMILE being a small incision lenticle extraction. So really what's happening is a very small incision is being made in the cornea. A femtosecond laser produces a lenticle in the window of the eye in the stroma. And then the surgeon goes in and removes that lenticle. So almost minimally invasive LASIK procedure in a way. I think really when I think about SMILE, that minimally invasive piece is important. And then there is some evidence, and the literature is a little bit mixed on this, whether or not because you're not severing a significant amount of the corneal nerve plexus, whether or not these patients get less dryness. And some of the studies would say it's about the same as LASIK. Others would say it's better. And so I think that there's advantages in regards to that. And I think for some patients, they like the idea of not having a flap created on the window of their eye. And so it's another option. I'm a believer in educating and telling them about options. And SMILE is just one of those refractive procedures that's still out there and definitely being utilized.
So, it's interesting, when we talk about, giving patients options. And I think for me, I like to definitively say this is, we can do, these are the risks, these are the benefits. And so you have that, especially when you think about, central corneal sparing or not making the flap. But I'm going to say something controversial. I don't really think that refractive surgery makes our eyes more dry. Prove me wrong. I'm holding that sign. The sign, the meme. Every one of you knows it, right? Corneal refractive surgery doesn't make your eyes drier. Prove me wrong. Justin, where are you at on that?
I think when I think of patients coming in for corneal refractive surgery, cataract surgery, there are so many that are already dry when they're walking in the door. I'm probably in your camp, Mark, in the fact that most of the dryness is missed on the front end. We're doing these surgeries, and then the back end, these patients are frustrated, and it's very easy to blame it on dryness. That was probably there on the front end. And that's why every patient that walks into my clinic, we have to prove that they don't have dry eye first before we're going to move through with the procedure. So it's controversial, but I'm probably siding with you on that one.
Appreciate it. People can write in the comment section. I don't know if there is a comment section. I don't care, but I'll go back to do you remember the patient reported outcomes with LASIK, the PROWL studies that were out there? So for those of you that don't know, there was a whole study, and I think it was it Shanslin who did it in San Diego? He was part of the PROWL 2, where they actually looked at service members, and then they also went into the public. Were you guys part of that?
We were part of the original PROWL study.
Yeah, nice. So literally what you did is you asked these battery of questions to patients before surgery. And then you came and you asked the same questions afterwards. So PROWL, or patient reported outcomes, what they would do is they say, how dry do your eyes feel? How much glare are you having at nighttime? Does your vision fluctuate? And then they asked them that after the surgery, and the dryness issue really didn't increase that much, and more importantly, neither did the glare issue. The two big things that everybody always says, oh, LASIK, dry eye and glare, so I feel that a really good candidate gets a good thorough evaluation. They're going to do phenomenal with corneal refractive surgery.
It's doing surgery on the right eyes, whether it's corneal refractive surgery, whether we're talking cataract surgery with advanced intraocular lenses, it's doing surgery on the right eyes. And if we're doing surgery on dry eyes or Eyes that have a really flat keratometry reading and they're high myope, you're going to hurt visual quality with those types of patients.
Yeah, totally. So you mentioned refractive lens procedure. It's funny is that there's been so many different names for it. Clear lens extraction, refractive lens exchange. God, what was the other one? That there was this whole. Do you remember when they were trying to dysfunctional lens syndrome? Do you remember that?
Yep, dysfunctional lens syndrome. You bet.
Yeah,
Remember all of them.
oh my God. I mean, the bottom line here is, it's, what we're doing cataract surgery, but you don't have a cataract and you have to pay cash. So we can call it what it is to patients. So I feel the Overton window for that type of procedure is kind of falling. In your practice, at what point do you now start thinking, moving away from corneal refractive surgery to maybe lenticular type procedures?
Yeah, it's a great question. I think the reason why we're more comfortable doing it a bit of a younger age, and I'll give ages here in a second, is because the technology has gotten so much better. We think of some of the new technology out there, the trifocal lenses or these EDOF plus multifocal combination lenses. They've just improved a lot. So it's a lot easier to offer this at a younger age. And the reason why that is we think of the natural lens as it's changing. In the past, would you want to remove a clear lens on a 48-year-old and put one of these technologies in the eye, one of the older technologies? No, because that patient's 48-year-old lens could still accommodate to a degree, and that new lens you're putting in the eye may not be as good, and the patient would be upset about that, rightfully so. Now, I would say that when we think of the technology we have in our hands that we can offer patients, I would argue that some of the technology is as good as that 48-year-old lens. So I would consider it. Now, for me, it's about 50, Mark. It's about 50. The reason why for me at 50 is I'm very confident that the lenses we have are as good as what a 50-year-old lens is. But also, I pay attention to the retina and posterior vitreous detachments. There is that risk if a patient hasn't had a PVD that they go inside the eye to remove a clear lens. Could you create the concern of a retinal detachment or a tear? So I do take that into consideration. If I have a 48-year-old that's motivated, that has had a PVD, that, I believe, especially if they're a hyperope, I have no problem talking to them about doing a refractive lens exchange. I would much rather them do that than have corneal refractive surgery.
I love how you said hyperope, because in the 1990s, the early 2000s, one of the first lens replacement procedures that I was a part of was the accountant for the surgeon I work with. She was a +7, and he just said, "You know what? I'm going to take your lens out." She was the happiest patient. So yeah, hyperopes, that's a sweet spot. Totally agree with you. But here's a question for you though. You had mentioned that you guys are part of some clinical trials for some new of the EDOF lenses, and technology is constantly changing. What do you do when a patient's sitting there and they say, "Yeah, I'm thinking about doing this, but I mean, you wait a year and there's a new iPhone, or you wait another year and there's, another edition," because this is one and done. This is we're not taking these things out every year and replacing them. And in fact, a lens replace or a replacement and removal, or what do you guys call it? We call them R&Rs. What do you call it?
Yeah, RLEs. We do call them refractive lens exchanges.
Yeah. So, you're not doing RLEs on these patients over and over again. So how do you deal with that, looking at the technologies?
That's a great question. I would say before the launch of these trifocal technologies, I did tell patients that we had better things coming. And that's not to be hard on the multifocal technologies, but a lot of times we were mixing and matching multifocal technologies and not maybe getting the results we were hoping for, or we were getting close. It was tougher. These trifocal technologies launched, or these EDOFs in combination with multifocals, and holy cow, Mark. I mean, the outcomes are just so much better in my opinion, and wonderful. And so right now, I would say that I'm not telling patients to wait, because is there new technology coming? Yes. Is it going to be head and shoulders above what we already have? I don't necessarily believe that. Where 5 years ago, before the launch of those other ones, I did believe that was happening, and it has happened. I don't think we're quite there yet. Will we have some accommodative lenses in the future? Yes. Could those be better than what we have? Maybe, because they behave more like the natural lens. But I don't tell patients right now to wait.
We could do this for hours. And for those of you in the comment section, if you want this to be like a marathon 4 hour, podcast, let us know. And I'm going to bring Justin back. But, one thing that I was thinking too is, how do you deal with people that have had previous refractive surgeries? So you have a 50-year-old. It's like, dude, I want to get guys. I had surgery, now it's not working anymore. Whether it be RK, whether it be even CK, or LASIK surgery, PRK. Do you guys do anything special or different for those patients?
Great question again, Mark. You're full of them tonight, which I
You know what? I am on fire, people. You know what? I just want to say, I take AG1, Justin. I'm using athletic greens, and people say to me, does it help you? Does it make a difference? I'm going to say it's the AG1. I'm going to just nothing to say.
So I take it as well, man.
Bro, yes, solid.
AG1 bros.
Okay.
To answer your question, so yeah, we do. So when we're talking about refractive lens exchange in a group like that, because they're in all the time because they've had previous refractive surgery, they've been happy for a long time, and now they're back at a point where maybe they're struggling with some of their near vision, intermediate vision. If they're in that 48 to above age group, we're talking a lot of them about the light adjustable lens. Although that's a lens that may not give them perfect near, I feel very confident I can give them arm's length dashboard intermediate vision with that particular lens. And it's customizable after we do the surgery. And so that is, to me, a perfect lens for post refractive, post RK, those types of things. If the cornea is really irregular and I don't like the way that looks, and we don't like an LAL, then we'll use a lens called an IC8, which is a little pinhole IOL. That can actually correct irregular astigmatism. It's the only IOL that can do that. And I've had some unbelievably great results for those patients that, maybe are having to wear a specialty contact lens, or just want some of that irregular astigmatism corrected.
I love that. So for those of you who don't know, the IC8 it was originally the camera corneal inlay, right? And so that's
yes. One's in the cornea. Of course, this is the implant.
Right.
Cataract implant. Yes.
And the beautiful thing about it is it uses, depth of focus. So you create this narrowing of their blur, depth of focus. So these patients, you may not get a perfect refraction. And I think that's part of the issue when you have previous refractive surgery. You change the cornea, the flatness, the curvature. And so getting that A-scan measurement sometimes is a little wonky. So you want to be able to titrate afterwards. And so I love the idea of the LAL. But I love the thought of using, the Bausch and Lomb lens, with that extended depth of focus. How would you decide between those two?
For me, it's irregular cornea, and a cornea that doesn't look quite regular versus one that does. If it's a regular looking cornea and not really irregular based on the tomographer, I'll lean LAL. If there's a lot of irregularity to the cornea, I lean a little bit more IC8.
Okay. So if you're referring a patient in, your patient says, I'm thinking about surgery, I want to get out of glasses. It sounds to me that our OD colleagues should look at them and just say, look, you know what? I'm going to refer you to a practice that does a lot of different procedures. They're not just pigeonholed into just everything's LASIK because it fits into a LASIK. And there's a procedure out there that can benefit you. But if there's not one, then they'll let you know. As opposed to us who are referring patients and just looking at a patient and saying, well, no, that's not a good idea for you. I know my question, it's not gonna garner, hey, that's a great question. And that makes me sad because I was on a roll, Justin. But do you understand what I'm saying?
It's an important question, Mark. It is a good question. It's an important one. Our colleagues need to start the conversation about these things because they're an option, and we've all taken an oath to give our patients their options and educate them. And even if it's saying what you just said, which is there's some options available from a refractive surgery standpoint, it may not be LASIK. You're building trust with that patient and they're going to appreciate that. So it's a great question.
I appreciate that, man. So any quick pearls you want to give, like, either pre-op or post-operative pearls that you can think of?
Celebrate with your patients these types of procedures afterwards. Some of them, it's going to take a little bit more time for them to adapt to get used to that, especially when we're talking IOLs. LASIK is pretty instantaneous, right? Day one, a lot of these people are very happy, but celebrate their vision with them. I think that's one of the joys that I get to do, on a daily basis is celebrating these procedures, because they're pretty nervous on the front end. Almost all these patients are nervous on the front end. And then I think my other pearl on the front end is over-treat the ocular surface. You can't over-treat it. Manage it, over-treat it. I would much rather have a patient come to me that has had ocular surface treated than me picking it up and having to do it and delay their surgery and so on and so forth. So over-treat the ocular surface.
Do you guys do anything ahead of time? Because I know like Ascaris and some of these other societies have looked at either immunomodulators such as, and lifitegrast like Xiidra, or even Mibo, I think, to use pre-op and post-operatively. Do you guys go that route, or do you individually pick patients?
Yeah, I'm very individualized. So I'm very patient specific, what's happening, on their surface. And I try to individualize it. So we don't have a protocol per se of managing dry eye. We're very picky about it, but I individualize it.
Awesome. Justin, you're amazing. I mean, when you said you're, celebrate with your patient, I feel that from you. And I think honestly, I don't do that. I'm a little older, but what I do is somewhat similar. And that is literally just when I walk in, I like them to see what it looks like using both eyes. And I like to be excited for the fact that look how much better they're doing. And so my pearl to anybody who's post-operatively evaluating patients, always look at binocular vision. Look at what they see, intermediate, close, distance, wherever it is with both eyes, and let your patients know how well they're doing. Because I sometimes, and this will be our last topic, is that I feel they look to us to say, how am I doing? As opposed to we are so used to asking patients, so how are you doing?
Oh, agree. They can sense confidence and they can sense when you're not confident. And so even if there's a problem, you need to be confident in educating them on that, because they can sense that. We talk to our residents or externs about that all the time, is if you go into the room and you're not confident, they're going to sniff that out and they will eat you alive. So be confident.
Yeah, totally. And one more thing. So if anybody wanted to learn more about this, I mean, is there a conference coming up that you're going to be a part of? Anything live that's super modern or something? Is that coming up soon?
You kind of hit it all. Mod Live is coming up in November 7th, 8th, and 9th in Austin, Texas. So we have a new location and really a meeting that's focused on the medical management and the surgical side of things for anything for optometry.
Awesome. That's really cool. I didn't realize it was moved all the way to Austin too. Mod Live. Awesome. Everybody, Justin, thank you for spending time with us. Thank you guys all for joining the podcast. And until next time, just, if you're listening to this in the car while you're driving, like I usually do, be safe. Be safe, everybody.